you very much, Chairpersons. It's again a great honor to be here for this congress. So I will be showing primarily the technique of Dcer, which I have developed over the past 10 years, and my own experience with this challenging pathologies for the past 20 years, and how we have evolved over a period of time to make this surgery more efficacious, more easier, and with better results. So these are few of my disclosures. The Dcer is currently registered with the US patent, and we are having research projects with Medtronics as well as with the Ministry of Science and Technology to develop some new instruments and new implants. So the Dcer technique is for congenital anomalies, which we very commonly see in this part of the world, where the C1 is fused with occiput, and there is a severe atlanto axial dislocation as seen here along with basilar invaginations. So this is what the technique of Dcer is. So there is absolutely no conflict of interest with the C1 C2 screw, which is placed if the C1 is not fused with occiput. Now, we have all trained with the transoral surgeries, and I would have done at least 300 of these cases before I started doing Dcer technique. So even though I was very proud of the CT scan image, but ultimately this is the kind of reduction which we would like to do, because fundamentally CV junction, cranio-vertebral junction is a deformity. So it has to be reduced, it has to be aligned, and the spinal cord compression has to be removed. And we published our initial technique in neurosurgery in the concepts, innovation and techniques. And now briefly talking about the mechanism of this technique. So the Dcer stands for the following words: distraction, compression, extension and reduction. So if you put a spacer, there is an 80% reduction of basilar invagination, but because of the tilt of the C2, the alignment is not proper and the atlanto axial dislocation is also not reduced. But if we apply compressive forces between the OC1 and C2, we get a completely perfect alignment like this. So if we have the OC1 here and the C2 here, when you put a spacer, there is a correction of basilar invagination to some extent, but most of the time the atlanto axial dislocation is still persistent, and that is where you start applying compressive forces, and this leads to a complete reduction of the AAD as well as the BI, and that's how the name has been devised by me. And this idea came across when I saw this picture of Archimedes when I was teaching my daughter several years ago, and I thought I could apply it for the CV junction. And I always prefer an occipital screw, because if you convert the spacer into a pivot, which is what the technique of Dcer is about, we have a long lever arm which enhances a very good screw bone interface tension. And then we published in neurosurgery about the newer indices. We described several newer indices, which includes cranio-cervical tilt, sagittal inclination, coronal inclination, the p-value of which was significant when we did various studies. And of course, we published in the latest Neurospine journal a complete treatise about the technique. So those of you who are more interested to know about the details of the technique can go through this chapter in the Neurospine, which is kept on the stall outside. And this is a measurement about the cranio-cervical tilt and how it improves following reduction. And this leads to also a correction of the entire spinal column and leads to complete realignment. And we have shown that this realignment of spinal canal is significant. Hence, it's a deformity correcting surgery. We have also published the series of 79 cases in neurosurgery, where we describe 3 types of Dcer surgery, but again, to emphasize, whenever the C1 is not occipitalized, we would prefer a C1 C2 screw, but whenever it is occipitalized, that is where the Dcer technique is to be performed. And this is another critique which was published in Neurology India, and I again suggest anybody of you who are more interested to go through this, as it would give you a complete idea on how the surgery is done. So in type 1 surgery, and the joint is almost parallel to the ground. That is where we do a straightforward translaminar screw with an occiput. And these are the examples of type 1 surgeries where the joint is more or less parallel to the ground. So just a translaminar and occipital screw would suffice, but more recently I prefer a 3-point fixation, which includes occiput, C2 and C3, or C3 and C4, in case the C2 screw is not possible. In type 2, we described a technique called as joint remodeling, where the joint inclination is between 100 to 160 degrees, it becomes more inclined. So we fashion the joints so that we drill with a diamond drill so that we are able to make the joint surfaces parallel, and then we are able to place the spacers inside and then perform the technique of Dcer. So putting the spacers. Now these were the earlier peak spacers, but now we have developed our own customized spacers. And this is how we used to reduce it earlier, but now we have a separate technique of reducing it. So that's how it is done. You convert it into a spacer. Now, the most challenging cases are the cases where the joints are completely vertical. So this used to be a contraindication for a posterior approach. But then, for the first time, we described a technique called as extra-articular distraction, where we showed that when the joint becomes vertical, you have something called as a pseudo joint, which is formed between the occiput and the proximal part of the pars. Now, this is an anatomical surety. So if the joint is vertical, you will find a pseudo joint in 100% of cases. The only question is we have to identify where the pseudo joint is. And you can place the spacer within the pseudo joint, and this can lead to a complete correction. So you can see a very severe BI and AD, and it has been nicely corrected by placement of the spacer, not in the true joint, but in the pseudo joint. And this is how the final fixation looks like. I prefer to use an O-arm. And I'll show you a few more examples. Due to lack of time, I would like to hurry up. So this is initial reduction, this is the final reduction, this is the pre-op, this is again the post-op. So you can see very severe compression with severe cord compression and a large syrinx. So we put 7 to 9 millimeter spacers, it didn't work out. And then we increased the height of, so this was Dr. Vincent Frenelis from Chicago, who had come to see this technique before we developed the instrumentation with Medtronics. So we increased the height of the spacers, after which we were able to get a good correction. So that's the pre-op and this is the post-op. So if the adequate correction doesn't happen, increasing the height of spacer would help. Few more examples. 11-year-old bedridden boy, severe compression, underwent some wiring technique outside. So you can see this is a true joint and this is a pseudo joint, some wiring here. So we put the spacers, so you can see this is a straight line, and when we start applying compression between the occiput and the subaxial cervical spine, the hyperlordotic subaxial spine starts correcting. So this angle now starts becoming acute, and now you can see a very good reduction has been achieved, and the cervical spine has also got corrected to a significant extent, and this is the final fixation. So you can clearly see the difference between the pre-op and the post-op corrections. And Dcer leads to a solid fusion. So after 3 years, you have a very good bone fusion and leads to complete stability. So I still have 7 minutes. I will quickly show you a short video before I end my talk. And I'll show you a few. So this is an example of an AAD with BI. And this is a true joint. You can see to some extent a false joint is being formed, but not so much. So we do a foramen magnum decompression and remove it as a flap that can be used as bone grafts. Drilling the lateral margins so that complete decompression can be obtained. Now because it is a pseudo joint, the joints have to be disarticulated. So the first part of the surgery is very, it has to be, the entire joints all around has to be completely disarticulated. So this actually takes a lot of time. So putting a spacer and reducing this actually takes only a couple of minutes, but a lot of time is taken in preparation of the joint. Just like total disc replacement, you have to spend a lot of time in disarticulating both the joints. So that's on the right side, and again on the left side. So that's the C2 ganglia which is coming on the way and is being cut out. So again disarticulating. So the joints have to be completely disarticulated before you put the spacers. And then it has to be drilled with a diamond drill so that the joint surfaces are completely prepared. And now we place these spacers, which are the special biconvex spacers, in this within the joint surfaces. And you can see you can use the periosteal elevator as a railroading technique before you load the spacers. And then you make a hole in the occiput, put a temporary screw there. So I don't use this technique anymore because it has some limitations, and I will show you what are those limitations. So pass a stainless steel braided wire. And then start twisting it gently. So as it twists gently, the spacers act like pivots, and this leads to a complete reduction of the atlanto-axial dislocation as well as the basilar invagination. So even if you don't have an OR, by looking at the, so you can see that's a very nice reduction. So even if you don't have an OR, you can see that when the hyperlordosis of subaxial spine starts correcting, you can be very sure that it has got corrected. And now we put a 3-point fixation in C2, C3, and we put the usual screws and fashion the rod carefully. So there has to be a single primary curve and 2 secondary curves. You can find the details of the video on the net. So that's how the rod has to be curved. And then we put the rod and then finally take off the wire as well as the temporary screw. And these are the type of spacers which we are creating with the Ministry of Science and Technology. It's a biconvex spacers. It has a very good grip. It optimizes the pivot-like movements. And then we developed this connecting screws which can connect to the rod as well as to the spacers, and this has been patented. So this is how the spacers can be connected with the rod, and which provides a very good rigid fixation. So a few more examples to show how we have placed the spacer with the connector. So you can see it's a very good fixation. Now the question is the wiring technique effective in all the cases? So you have it AAD which is very severe, coming almost until the base. I don't think you can even do a transoral here. And in this case we used a wiring technique, but what happened? While we were able to reduce the dents completely, we were not able to reduce the atlanto-axial dislocation. So what exactly happened? So in mild to moderate BI and AD, there is only a dislocation around a single pivotal point. But when the basilar invagination becomes more in severity, there is a backward shift of C2. So there is a disthesis backward. So even if you correct the C2, these two lines will not align with each other. So there is a backward disthesis, and it happens with very severity. So in order to correct this, we would also require a compressive force over the C2 so that this disthesis can be corrected. So ideally, in this case, we should have used some kind of force to push the C2 forward so that we could have attained a reduction like this, which is a Photoshop image. But this is how the ideal reduction should happen, because in this case, the BI was so severe that there was a backward shift of the C2. So I started thinking about it. Then I went back to my drawing board and I started working upon a universal reducer. So these are the initial drawings that I did. So I worked upon how we can develop this, and even tried using some wires in order to develop this. And I took this idea through Metronics, and they really liked it because it's a universal reducer and it would in effect enhance the capabilities of the vertex system. And then I got it patented in the US, PCT. And then we developed this universal reducer, which will be out in the market very soon, hopefully. And as you can see, this has a wire which goes around the C2 and comes around the hook here. So you can press this, and then you have a C2 translation which can actually press the C2 forward in order to reduce it. So it adds a T to the Dcer. It becomes essentially a DC ETR, where T stands for translation or a pushing force onto the C2. And we developed a special type of wire tensioner which has a 7.5 times stronger than the usual Atlas cable. And this is how it looks with the universal reducer in C2. And this is a 3D OARM image. Video is not working for some reason. So, few examples to show how we used the universal reducer. And this is how it looks. So you put the wire tensioner as well as a C2 translator, and you use both the mechanisms together. So in effect, it becomes very easy to deal with any severity of PI and AD, and it takes care of the situ translation and avoid all the hassles. So this is a reduction without the universal reducer. You can see there is no reduction of translation. Now we operated on a similar case by using the universal reducer. You can see that the dense has been very beautifully translated forward, leading to a complete realignment and reduction. And this is the universal reducer in situ. I will finally end with this case, a highly complicated case which shows that to do is, if you know what to do, you can do it perfectly, otherwise you can end up having a problem. 14-year-old female, this is what the scan showed. Underwent first surgery which was outside, which underwent wiring. Came back again with increasing symptoms, so you can see densers going backward inside. This is the MRI. Again underwent a second surgery outside, where the surgeon fixed over the wiring. Was alright for a few months, and then again, once again started developing symptoms when the dens started invaginating. And again went back for a third surgery with the same surgeon who extended the subaxial fixations. And again started deteriorating because the dens started prolapsing again. And for the fourth time he came to me, and this is how it was when the patient came to me the fourth time, and you can see severe compression at the cranio-vertebral junction. And we used the universal reducer, and we were able to provide a complete reduction. I will show you the final. Can I go back? Could you go back one slide? One more slide backwards. One more slide. Yeah, this is the final reduction. So you can see we achieved good reduction. And the whole surgery got over in just 45 minutes. So the journey has been long, but I think it has been worth by traveling with friends, strengthening old ties and making new ones. So Dcer in our experience has been safe, efficacious, can be applied to all severities of PI and AD. And by the development of new implants and instrumentation, this challenging pathology to tackle has become much more easier. Thank you, and apologies for taking that extra minute because of some confusion.
Thank you very much, Dr. Chandra.